So good evening, everybody. Welcome to the Product Theater sponsored by Eli Lilly. The first topic that I have for today is glucagon-like peptide receptor agonists, the cardioprotective effects, a kind of a review that I would like to do. Before I get started, my standard disclosure. My name is Indranil Bhattacharya, and I'm a full-time Lilly employee. I work with medical. Now, when we talk about GLP-1 based therapy, we have traversed a certain distance, and starting from the endogenous GLP-1, which is released within the body, and this was discovered quite a number of decades back, we have looked at different products that have evolved over a period of time. We have the short-acting exenatide by the commercial name of Byetta, which was launched twice daily. And then we have lixisenatide, which is a once daily, though with a very similar kind of a half-life as exenatide short-acting. Then we had the first truly once daily GLP-1, which is liraglutide, which had a kind of a fatty acid chain. And then we had the uh, extended action GLP-1 RAs with once weekly biduron or exenatide. And then we had albiglutide and dulaglutide, which are again once weekly. Very recently, we have had an approval, though of course not approved for India, is the once weekly semaglutide injectable. And of course, we will soon have the oral semaglutide as well, which is again once daily. So there has been a distance that has been covered during this GLP-1. Now, we all know, and when we talk about the incretin effect, and we do understand that in a normal person, and this is designated by the IV glucose, which is oral, which is yellow, and the violet line, which is the oral glucose, that when it comes to the C-peptide corrected insulin levels, there is a difference that sets in when people take glucose intravenously versus orally. Now, this difference is what is classically known as the incretin response that we normally see. In a type 2 diabetic scenario, not only is the baseline blood sugar levels elevated, as we can see, the baseline is here, and thereafter it rises further, and it doesn't really come back to normal. And what we can appreciate on the right-hand side of the cartoon is that this incretin effect is grossly diminished. Now, when GLP-1 RAs, the mechanism by which they act, of course, these are hormones that are released into the small intestine. And please remember, this is secreted in response to the food. And the GLP-1s, they have a number of actions. Like, for example, on the brain, they do act on the satiety center to decrease the appetite and cause early satiety as well. And of course, decrease appetite. They do act on the pancreas to stimulate the insulin secretion in a glucose-dependent manner, and through an indirect mechanism also causes suppression of the glucagon axis, which reduces the hepatic production of glucose. The GLP-1 RAs also, they do act on the stomach and delays the gastric emptying further. So these are the broad mechanisms of GLP-1 RA that we know of. Now, when we talk about the conventional GLP-1 RAs or the GLP-1 RAs that we have, we do have some benefits and we do have some limitations. Let me just talk about the benefits first. Of course, there is a high efficacy that is perceived with this class. And most importantly, the human GLP-1 RAs as liraglutide, dulaglutide, and of course, semaglutide as well, in comparison to the exendin 4 backbone GLP-1 RAs, which is like exenatide short-acting or lixisenatide, or even exenatide once weekly. Some of these GLP-1 RAs, they do have a cardioprotective effect, and we will talk a bit about that later. There are some renal benefits as well. There is, of course, a lower risk of hypoglycemia because most of the GLP-1 RAs, they act in a glucose-rich environment. They do have an additional benefit of weight loss. And of course, this is variable with different GLP-1 RAs. Most of them, they require either a minimal or no titration. And of course, there is an oral option, as I said earlier, with an oral semaglutide. However, there are certain important limitations. There is a GI side effects that is a prominent thing with this class, with nausea, vomiting, or diarrhea. It doesn't necessarily mean that this happens with all patients, but still GI side effects are seen, at least nausea, in a large number of patients. Most of the GLP-1 RAs are injectable, though, I mean, with the very friendly devices, and we will talk about that a bit later. The pain, though, is minimal, but still it's an injectable. And this, of course, can affect the adherence, and of course, injection site reactions are possible. There is a FDA black box warning on the risk of thyroid C-cell tumors with some of the GLP-1 RAs. And of course, though this is not yet proved and largely accepted by the FDA that there is no risk of pancreatitis per se, but most patients or most physicians would avoid them in a patient who has had an history of acute pancreatitis in the past. Now, when we talk about the GLP-1 RAs, now if you look at the table, I mean, there are different options available, of which we will not spend much time about albiglutide and exenatide once weekly because they are not yet available in India. Largely, the two main important ones that are available right now is Trulicity, which is once weekly dulaglutide, and of course, we have liraglutide, which is once daily. Lixisenatide is available, but is used in a very few numbers of patients, and exenatide short-acting, again, in very, very less number of patients. Talking about dulaglutide and liraglutide, while dulaglutide is once weekly, its half-life, its Tmax is about 48 hours. The half-life is about 4.5 to 4.7 days, which facilitates a once weekly injection. The time to steady state plasma levels takes about 2 to 4 weeks. So you require that amount of time to achieve steady plasma half-life. It's available as a single pen, which is a single dose prefilled pen, either as a 0.75 or 1.5 milligram. So it's just a pen that has to be used and for 1 day and then throw away. There is no reconstitution required. The needle, and we will talk a bit about that, it's pre-attached, so there is no need to attach a needle to the Trulicity device. In fact, the needle is not seen. It's hidden, of course, and no priming is required. We do have some amount of injection site reactions, but it's very less, 1.9%. Talking about liraglutide, its half-life is about 8 to 12 hours, for which it is required to be given once daily. It's available as a multi-dose prefilled pen. Of course, there is a titration that is required, though no reconstitution is required, and you have to attach a needle as well. In the liraglutide lead trials, the injection site reaction was about 2%. And of course, in the more than 26 weeks duration trials, it was about 2%, but most of the reactions were usually mild. Since we talked about the GI side effects, now this cartoon actually shows you the extent of nausea, vomiting, and diarrhea. These are the three most prominent GI side effects. Of course, some patients do have a constipation as well. The amount of nausea that we see, this is the most common side effects. And of course, it affects more or less about 20% with Trulicity. With albiglutide, this is about 10%. With exenatide twice daily, this is about 80 to 20% around. And liraglutide, it is about 22%. Lixisenatide about 20 higher, more than 25%. And exenatide short-acting a bit higher with 30%. Similarly, vomiting is less common than nausea, but still about 10% largely, as you can see. And diarrhea, again, between 10 to 15% with most of the available GLP-1 RAs. Of course, since we talked about the two backbones from which GLP-1 RAs are prepared, there are some similarities, and of course, there are some differences also, even within molecules of the same backbone. Now, from a similarity perspective, they all have significant glycemic improvement. Most of the trials have shown that where there is a significant A1C reduction, fasting and postprandial blood sugar reduction. There is a lower risk of hypoglycemia, which is accepted now because it acts in a glucose-rich environment. Most of the trials have shown variable weight loss as an additional benefit, and usually this is dose-dependent and, of course, gradient-dependent as well. There is some amount of reduction in systolic blood pressure. It's not too much, but it's about 2 to 3 millimeters of mercury. GI side effects, of course, and of course, the label warnings regarding pancreatitis. The earlier molecules like liraglutide and lixisenatide They had the warnings kind of thing, I believe, as members, first members of the class. The later on GLP-1 RAs, and of course with our revised understanding, this label has been withdrawn with many of the newer GLP-1 RAs, including the older GLP-1 RAs as well. And of course, there is a potential effects on beta cell survival, CV outcomes. The beta cell survival, of course, is not yet shown very conclusively in human beings, but CV outcomes, yes. And there is some amount of speculation on the neurodegeneration, of course. At present point of time, this is largely off-label. From a differences perspective, either the molecules can be human GLP-1 or and because of that, there can be a variable immunogenicity. The onset of action is different. The effects on gastric emptying are different within the molecules. The fasting glucose and the postprandial glucose reduction, the magnitude of it, that's different. There is a difference in potency in terms of A1C reduction and weight reduction as well. Because of their variable half-lives, there is a differences in metabolism and elimination. Some of the longer-acting GLP-1 RAs are not excreted by the kidneys. For example, dulaglutide, there is a potential for kidney protection, though large kidney outcome studies are absent with the GLP-1 RA class. And of course, based on the frequency of administration, dose titration devices, pens, there is a variable effect on adherence and persistence to therapy, as we see with different members of the GLP-1 RA. Now, with that, let's now get into the cardiovascular benefits. Now, this has been our understanding that people with type 2 diabetes are 2 to 4 times more likely to develop cardiovascular disease compared to someone who does not have type 2 diabetes. Now, just because of the diabetes per se, the risk is doubled or quadrupled in some of the patients. Now, this has been largely the newer guidelines, and this is the ADA-ASD consensus statement, wherein when we took a kind of a departure from the earlier guidelines, wherein after metformin, there were different classes of therapy that were approved, like SUs, TZDs, metformin, TZDs, DPP-4 inhibitors, GLP-1 RA, or basal insulin. In 2018, this approach was largely modified by the ADA-ASD joint body, and now we can see that based on the presentation, there are some preferences within the class. For example, if a patient has established cardiovascular disease or risk factors for cardiovascular disease, choices are two. One, if it's predominantly atherosclerotic cardiovascular, GLP-1 RAs are the preferred ones. On the other hand, if the patient has an element of heart failure or chronic kidney disease, it's the SGLT2 inhibitors, which is the preferred class. And thereafter, you go on up titrating that depending on the HbA1c response. On the other hand, if there is a compelling need to minimize hypoglycemia, GLP-1 RAs are again preferred. Similarly, in some patients of type 2 diabetes where there is an incentive or there is an intention to cause weight loss, either by the patient or by the physician, GLP-1 RAs with proven weight benefit are again preferred. And of course, for the first time in the guidelines, they came into consideration for costs as well. Now, if you carefully look into this entire guidelines, and look at the prominence of the GLP-1 RAs, this is clearly about 13 times with different indications with this atherosclerotic cardiovascular disease, minimizing hypoglycemia, or to have an additional component of weight loss in a patients of type 2 diabetes. Now, when we talk about the GLP-1 RA cardiovascular outcomes, we have most of the trials have been published in the last decade. And based on the dates when these trials were completed, they could have been published later on, of course. We have had a robust understanding as to how these molecules act, what are the benefits that are seen with different classes of drugs. Last year itself, we had two, and we will talk a bit about the REWIND study, which is the cardiovascular outcome study with dulaglutide. But along in the same conference, ADA last year, we also had the Pioneer 6 study with oral semaglutide, which failed to show the superiority, though achieved a point of non-inferiority. Of this, the Freedom CVO, it's largely an investigational molecule with a once yearly exenatide to be given subcutaneously under the skin. This is IPCA 650 and has not yet been approved. And of course, we do have superiority data with liraglutide and semaglutide injectable as well. And semaglutide injectable as well. Now, when we talk about the rewind, and basically what we have done here is we have put the other CVOTs with the GLP-1 RAs in this perspective. Uh, there are certain points of differentiation of the rewind study when it comes to the other cardiovascular outcome trials. For example, the first is, of course, the women participation, which is about 46% in the rewind study, as 30 to 36% or 38% in the other cardiovascular outcome studies. One of the contrasting features of rewind, which sets it apart from the other cardiovascular outcome trials, is the patient population with prior cardiovascular disease. In the other cardiovascular outcome trials, this was largely 80% and even 100%, for example, in the lixisenatide ELIXA study and the Harmony outcomes, which is with albiglutide. This 100% in the lixisenatide ELIXA study was actually post-MI within the last 3 months, but in the others, it was all 80% and above. In contrast, the Rewind study only had 31% with pre-existing cardiovascular disease. The rest, 69%, had just patients with risk factors. The other point of differentiation is the low A1C in terms of the Rewind, where they started at baseline. And that is because most of the other cardiovascular outcome trials, they had a lower HbA1c cutoff value of less than 7 to be eligible for the trial, and had no higher HbA1c cutoff value. Rewind, on the other hand, had a higher HbA1c cutoff value at 9.5, and there was no lower cutoff value. So most of the patients who got enrolled in this trial, these are type 2 diabetics patients as seen in routine practice. And the mean HbA1c where they started was about 7.3. Now, because we were primarily looking at a lower risk population in the Rewind study, the period of follow-up that is available with Rewind is the longest. This is about 5.4 years. And of course, this goes a long way to put us, to assure us about the long-term safety data of this molecule. And we talked about the women, the prior cardiovascular disease, and the longest follow-up as well. Now, we talked about the risk. Now, if I look into the annual MIS rates in the placebo arm in the different cardiovascular outcome trials, in ELIXA, this was the highest. Within last 3 months post-MI, 6.3 events per 1,000 patients per year. Harmony, this was about 5.9 events, Sustain 4.4, LXL 4, and Leader 3.9. In contrast, the Rewind, the placebo group, had only an event rate of 2.7%. So this was primarily a very low-risk population, patients as would be seen in normal real-life practice. Now, what it showed over a period of 5.4 years, the dulaglutide in the Rewind study, it did show a 12% relative risk reduction, 12.9 versus 12.4 versus 13.9 events in the placebo arm, an absolute risk reduction of around 1.4% roughly. The two curves, they start separating at 1 year and thereafter they diverge because a Cox proportional hazard ratio model was followed in this study. So the benefit of 12% relative risk reduction applies to every point that is pre-specified on the x-axis, whether it's 1 year, 2 years, 3 years, 4 years, and 5. The median follow-up, of course, with 5.4 years, and effects were consistent in patients both with and without pre-existing cardiovascular disease. This, ladies and gentlemen, is the 3-point composite MIS individual outcomes. Let's look at cardiovascular death. The hazard ratio is 0.91. The p-value for interaction is non-significant. It's a very narrow confidence interval between 0.78 and just crosses the point of unity. Non-fatal myocardial infarction, about a 4% reduction there. Relative risk, the p-value for interaction is not significant. And when it comes to non-fatal stroke, overall a 24% relative risk reduction. It doesn't cross the point of unity, and the p-value for interaction is significant. Now, what is very reassuring is that though this trial was not powered to look into individual outcomes, it's very consistent that most of the benefits, they're all in the same direction, whether it's cardiovascular death, non-fatal MI, or non-fatal stroke. And overall, it did show a point of superiority in the 3-point composite MIS, which is the primary objective of the trial. So if I have to summarize the Rewind summary, people with type 2 diabetes with higher cardiovascular disease, they were randomized in a 1:1 fashion to receive either dulaglutide 1.5, There is no 0.75 here. And of course, the other arm, they received a placebo injection, which was double-blinded. They were followed up for about 5.4 years. It did show a significant 12% relative risk reduction, 12 versus 13.4, which translates into a 1.4% absolute risk reduction. And this met the criteria for superiority. The CV death and non-fatal MI, non-fatal stroke, they all show a trend towards benefit. So it's all homogeneous data. Some other endpoints, which were like secondary objectives, were congestive heart failure and hospitalization, 4.3 versus 4.6. And of course, the composite microvascular outcome, largely driven by the kidney outcomes. But again, this was exploratory in nature. This was 18.4 versus 20.6%. The composite renal outcome, this translated into a benefit. But again, as I said, that whether it's composite microvascular or just renal outcomes, this is largely hypothetical or exploratory in nature. Overall, the conclusion was that it is superior to placebo. That's another point of differentiation, that REWIND was designed as a superiority trial, and it did show superiority to placebo in reducing CV events in middle-aged and older people in type 2 diabetes, in both categories of patients, people with disease and those with the risk factors as well. So if I have to summarize the summary of the GLP-1 receptor agonists, as you can see, the ones that are highlighted in red are the ones that are significant from a superiority perspective. Leader, this translated into a 13% relative risk reduction. Sustain with semaglutide injectable, this is about a 6% relative risk reduction. Harmony and albiglutide, of course, this molecule is no longer available in majority of the markets. This is a 22% relative risk reduction. And of course, REWIND, it did show a 12% relative risk reduction. Pioneer, of course, as I said, did not show the point of achieve the point of superiority, and that's the p-value for interaction. Of course, it did achieve the point of non-inferiority. Now, ladies and gentlemen, the pertinent question that comes is, what is the selection criteria for a GLP-1 RA? Now, we do understand that when one is prescribing a GLP-1 RA, you will have to look at the comorbidities. We talked about it in the ADASD guidelines. So patients with cardiovascular risk or cardiovascular disease risk, some patients do have a component of weight loss that is desired in them. Of course, glucose lowering effect, that is important because GLP-1 RAs by and large are glucose lowering drugs. Of course, if you want to avoid hypoglycemia and of course, certain contraindications which we talked about. But with this pertinent selection choices, there are certain other practical considerations as well. One has to look at the device and of course the friendliness of the device. Is it pen which is ready to use, or does it require a reconstitution? Does it require the needle to be attached? And does it, of course, do you require reconstitution of the drug? The next question comes, how frequently it has to be dosed. Is it once daily, twice daily? Is it once weekly? And how much of a titration is required. And of course, from a patient perspective, does the patient feel confident with this self-injecting? Are there concerns about adherence to therapy? Does the patient have regular meal patterns? Has the patient experienced a preference? Now, by and large, when we look at this entire scenario, we do see an overwhelming preference for patients for once weekly options rather than a once daily kind of thing. And that's why most of the adherence and persistence data is in favor of that. This, ladies and gentlemen, is the abridged pack insert for Trulicity. As I said, it is available in two strengths of 0.75 and 1.5 milligram once weekly. The indication for dosage is 1.5 milligram when used in combination therapy with existing oral hypoglycemic drugs or in combination with insulin. You can use 0.75 as a starting dose if it's in patients with, as used in monotherapy or in some frail patients. Apparently, from a contraindication, the only contraindication is if there is a hypersensitivity, because of course you need to be a bit cautious when using it in patients with the history of pancreatitis, though it's not an absolute contraindication. Of course, there is no data which once weekly Trulicity in pregnancy patients, and that's why the use is not recommended. And of course, there is no recommendation for its use in pediatric patients or patients of type 2 diabetes below 18 years of age. Again, it is not approved for usage in patients of type 1 diabetes either, or in usage of hyperglycemic emergencies in hospitals. That, ladies and gentlemen, was the last slide that I wanted to show before I go on to the Humalog 200. If there are any questions, comments, concerns. Should I continue?
Yes, sir.
Okay. The next thing, of course, from a Lilly diabetes perspective, we do have different products. For example, Humalog Mix 25, Mix 50, and Humalog 200 as well. We'll talk a bit about the Humalog 200 here in this product data. This is the concentrated bolus insulin, and the question is, what are the added benefits? Let's look at that with the help of a patient profile, which is hypothetical. And of course, again, my standard disclosure, I'm a full-time Lilly employee. Now, we do understand that postprandial hyperglycemia, and given the caveat that we live in India, where there is a carbohydrate-rich diet, patients of type 2 diabetes, they present late and often with very elevated postprandial hyperglycemia. There is no doubt that there is a direct correlation with different disease and comorbidities like macrovascular, increased risk of pancreatic cancer. There is an increased risk of carotid intimal media thickness. I'm sorry for the typo over there. There is a correlation with myocardial blood flow or volume, with diastolic dysfunction that is seen in commonly in type 2 diabetes, oxidative stress, so hence and so forth. Most patients, and of course, contrary to the popular belief, which was laid out by Monnier, that you need to treat fasting first. Now, what has been the observation, and this is, of course, fueled by data more from Asian countries, East Asia, South Asia, that just targeting the fasting might not get your patients to the target A1C always. And what we have seen is, as you can appreciate, is that if it's just the FPG, where you are targeting less than 100, it's about only 64% of patients who reach target A1C of less than 7%. However, if you make the PPG as a target and your target is less than 140, it's about 94% of your patients who reach target A1C. So that's roughly the split and the renewed understanding that we have in this regard. With that, I present Mr. Ram Narayan, who is 68 years of age. This is a hypothetical scenario, of course, diagnosed to be 18 years of age. The HbA1c visit is about 8.4%. And currently, Mr. Ram Narayan is on Humalog, insulin glargine, an SGLT2 inhibitors, metformin, and a DPP4 inhibitor. So largely optimized therapy, given the scenario that he is type 2 diabetics, long duration. Now, this has been his patient history that we have kind of built up there. As you know, I mean, this patient had history of trial with premixis, which we know is tried in many lot of patients, Indian patients as well. And of course, as the disease progressed, he was started on a basal plus therapy, which was gradually upgraded. And now currently he's on basal bolus therapy. And of course, somewhere down the line, a DPP4 inhibitor and an SGLT2 inhibitor was also added to his treatment armamentarium. His HbA1c currently is 8.4%. He does have a problem with body weight. There is comorbidity history with hypertension. He does have a history of obstructive sleep apnea. Most importantly, he is on insulin glargine, about 20 units per day, and Humalog, 10 units before dinner. The other medications for his comorbidities is diltiazem, 120 milligram once daily. He is on metoprolol, and of course, irbesartan for his blood pressure, and hydrochlorothiazide combination. This has been his HbA1c, as you can see, starting from 8.1, this went up to 11.3 somewhere before lunch. The pre-dinner is about 10.5. This is in milligrams per deciliter, and at bedtime, it came down to about 128. So very clearly, there is a problem pre-breakfast, And there is a larger problem pre-lunch and of course pre-dinner as well. From his individualized goal perspective, it was agreed that his A1C should be less than 7%. The FPG target is 180 to 130, and PPG should be less than 180. Now, what the physician did was his insulin glargine dose was increased to 24 units. Humalog, which was currently 6, 6, and 10, this was changed to Humalog 200, and of course, SGLT2 inhibitors therapy was maintained. Now, why did we change it to Humalog 200? The treatment objectives was, of course, to to improve the mealtime control, which, to our earlier understanding, possibly have a better chance of achieving HbA1c targets. Of course, lifestyle was reinforced. The rationale was that we wanted to reduce the number of pens that he had to buy in a month, kind of thing. And of course, because of the concentration of Humalog 200, which is 600 units of insulin in 3 ml, 200 units per ml to reduce the volume of mealtime insulin, and of course, give it through a pen, which is very easy to administer. Now, when we look at, and of course, there is a paucity of data from the Indian subcontinent or this part of the world on mealtime insulin requirements. But if we look into the Western European or the European counterparts, most patients, more than 60% of the Western European people, whether it's type 1 or type 2, they use more than 20 units. So that's about 15%. 21 to 29 units, 10 to 14%. And 30 to 39 units, 7 to 10, and so hence and so forth. But more than 20 units per day is a large numbers of patients, and it's about 60% of patients who require, of type 2 diabetes, who require that dose of insulin, whether it's type 1 and type 2 patients, that's applicable. Now, we looked at Asian data, which is in about 312 Asian patients, and there we saw that the average dose requirement is about 37 units per day, and of course, about 41 units per day for the insulin experienced population at the 24-week endpoint. So 37 units in patients who were new to insulin, and with patients previously on insulin, this was a bit higher, which is understandable. So this is what the split is all about. Now, the question is that whether it's a patient's patients with increasing BMI, and as you can see that irrespective, that is an insulin dose requirement, not only in patients with higher BMI, which is the popular belief, but even in patients which BMI is quite less, they do have a higher insulin requirement in certain cases. And as you can see, of course, obese patients do have a higher requirement, but it's not that the non-obese patients don't have a higher dose insulin requirement, especially the prandial insulin requirements. In this background, this is Humalog 200, and this is for a quick pen, and this is how the pen looks like. Now, from a bioequivalent study perspective, this was compared with Lispro 100, and as you can appreciate, that from a PK perspective and a pharmacodynamic perspective, which was through a glucose infusion rate, these two curves are exactly identical. So from a bioequivalence perspective, Humalog 100 and Humalog 200, there is a 1:1 dose conversion that is possible because of this bioequivalence. Now, when we talked about patients as to understand as to what they found easy when using a Humalog 200 quick pen, some of the factors that came up as a preference for patients is they find it convenient to use. It's easy for patients to administer Lispro 200 when instructed to switch from 100 units. Patient use Lispro 200 insulin as prescribed, fewer split doses, and of course their adherence. So there is a kind of, these are the attributes which was kind of highlighted. And of course, we did see that physicians, they do prescribe Humalog 200 quick pen more to overweight or obese people who more than 20 units of mealtime insulin per day. Now, When we looked at the preference again, the four more important attributes which came up was overall preference. 80% of the patients, they preferred the Humalog 200 over the Humalog 100 quick pen. And some of the attributes which drove this preference was the total amount of insulin in the pen, the easy to press inject, the button inject, the amount of fluid injected, so there was a volume perception, and overall easy to use pen. These were the three or four more attributes that were picked up by patients. There are other attributes as well, the color of the pen, shape of the pen, easy to learn use of pen, but this had a minimal impact. Overall, it's the first 4 or 5 which drove this overall preference of close to 90%. Towards a Humalog 200 quick pen as compared to a Humalog 100 quick pen. Now, let's look at the recommendations that is there from the ADA and the other bodies. If I look into the local RSSDI 2019 recommendations, what they say is that short-acting, high-concentrated insulin can be administered to people who have severe insulin resistance and need higher doses in a single injection. The ADA 200 recommendations is that concentrated preparations may be more convenient and comfortable for patients to inject and may improve adherence in whom there is an insulin resistance who require large doses of insulin. Now, let's come back to the Mr. Ram Narayan as to what happened. Now, this is the insulin used before first visit. And this is when on the experience with Humalog 200. So there is a decrease in the fasting blood sugar level, which is pre-breakfast to 121. The pre-lunch has come down by 164 from 204. From 190 pre-dinner, it has come down to 86. And of course, 128, 217 at bedtime, courtesy when insulin glargine was being administered. And of course, when we talk about patient outcomes, from a patient's perspective, what the advantages with Humalog 200 is that the requirement of a replacement is less because it's now 600 units per pen as compared to the 100 ml quick pen. And of course, if the patient is traveling, you require to cover just one pen with you or lesser number of pens because of the lower volume that is required. From an HCP perspective, what they have noted, better cooperation with the patient and increased motivation. And of course, the relationship. This is a bit hypothetical because of the data there. So that from a decision summary perspective, this increased Ram's confidence to help him achieve his glycemic control target and a better therapy that provides his lifestyle. And of course, the rationale was that the switch, the lesser number of pen requirements, the lower volume requirement, this became a bit more pleasant with Mr. Narayan. Patient outcomes, and of course, they require less number of pens to carry, less volume, and of course, the Humalog 200 quick pen has a larger glide force as compared, it requires a lower glide force as compared to the 100 ml quick pen. And these are the perspectives, anecdotes from a patient or a physician perspective. Now let's look at the next scenario. Now, when we look at patients who have problems with injections, for example, a limited joint mobility syndrome, old patients who have self-determination and are willing to go for a basal bolus therapy. That's why they need to be mentally fit, and I want to avoid. But because of their joint dysmobility, where there's a thumb arthrosis, and frailty or a recurring thumb pain, wherein the injection, if it's smoother to use, it's always a welcome thing. And that's exactly where the reduced glide force with Humalog 200 becomes a kind of an advantage. The glide force, ladies and gentlemen, is the measure of effort that is required to depress the patient's pain's injection button. And study comparing the glide force between a 100 ml quick pen and a 200 ml quick pen, it showed a significantly lower maximum glide force, average glide force and glide force variability than the quick pen across all combinations of dose, size, dose speed, and needle type. And of course, they require a 48% less average injection glide force than the Humalog 100 quick pen. And this is a small study with 61 subjects with limited joint dysmobility syndrome. Of course, remember that these two insulins are bioequivalent, so we are not really expecting a change in outcomes in terms of fasting blood glucose, HbA1c, hypoglycemia rates, and all. The dose requirements are essentially the same. But what we saw was that there was a significant improvement parameters with around 20% decrease in insulin requirements. That goes there, maybe because of the injection experience that was improved. And patients' answers to the question that there is a higher preference for Humalog 200 Lispro for continuing treatment due to fewer difficulties completing the injection. Checking on this was a recommendation that it does make sense to understand if patients do have a problem injecting, and with patients with limited joint mobility syndrome, if you are using a basal plus or a basal bolus approach, which requires number of injections per day in a patient of type 2 diabetes, Humalog 200 could have a solution there because of the better glide force there. There's another, of course, is the insulin resistance. We talked about the guidelines. So basically, classically, this is more than 1 units per kg per day, or patients requiring more than 2 units per kg per day, or a daily insulin requirement of more than 200 units per day and of course, as we can understand that if it's a 100 ml quick pen that you are using, this would require a larger volume to be injected and a very frequent injection devices requirement as well. So ladies and gentlemen, that could be a third scenario where you could look at Humalog 200 as well. So if I have to summarize the differences between Humalog 100 and Humalog 200, both patients, you can only give 60 units. So anything more than 60 units, you cannot give in a single dose. That would require a separate dose. But the Humalog 100 quick pen has only 300 units, and this has 600 units in one pen. The dialing dose requirements in single unit requirements, and of course, because they are bioequivalent, it's an identical dosing. However, the volume of a requirement is essentially half, from 0.4 ml. This is about 0.2 ml. And of course, as the current pricing goes, the Humalog 200 quick pen is about 25% lesser priced than 2 pens of quick pens bought together. So from a summary perspective, and this is my last slide, I essentially believe PPG is an independent risk factor for complications and mortality, and possibly, and more patients do achieve HbA1c targets by adhering to PPG targets than FPG targets. There were many patients of type 2 diabetes who require a higher dose of bolus insulin. They can be obese, they can have insulin resistance, or because of the progressive nature of type 2 diabetes, Humalog 200 quick pen can be considered in many of these diabetic patients who have more than 20 units of bolus requirement per day. They require fewer pens. They require a less volume of injection, and because of the better glide force, it's easier to press. Special populations, like of course patients with severe insulin resistance, high insulin dose requirements, patients with impaired hand joint mobility or dexterity issues could benefit from the 200 quick pen because of the smoother glide force requirements. And of course, that's what the overall requirement is. So if there are any questions or comments, and last but not the least, we do have the Life 360, which is our integrated patient support program, which kicks into action with this call to this toll-free number by your patients. And thereafter, we do offer a plethora of services, whether it's in terms of a life kit, tele-education, face-to-face education. In some select cases, there are self-education tools. Availability for a longer period of time during the day, and of course, the adverse event and the product complaint there. There is a life kit in this Life 360, which helps patients or assists them through the initial steps of their insulin initiation. So my request would be that physicians who use these services do pass on the benefits of this toll-free number to your patients. They can give a call and they can enjoy this integrated patient support system as well. So that, ladies and gentlemen, is the last slide that I had. If there are any questions or comments. Any questions or comments or concerns? Hello.